Hi, Ria. Good evening, Dr. Saurabh. Hi, Milind. Hi, Dr. Parveen.
Hi, Dr. Emil. Dr.
Hi,
Emil,
Saurabh.
will they need PPT, like will they present PPT?
Yeah. So each one will have their PPT.
So I have to make an co-host, like when they uh,
Yeah, yeah, yeah.
so
So actually, then how
Ria,
will you
I'll make
know? So
co-host
the
to
order is
Ria.
first Swati. The order first is Dr. Swati. Then after that, you have, according to that
Yeah. So
presentation.
yes. Yeah. Ria, I'll make co-host.
So yeah, Swati, Milind,
Or Millie will join.
Abhinaya. She's yet to join.
Yeah.
Ria.
Ria
And
join.
Ria is co-host. Yeah. And who else? Mm. Bala has joined.
Bala join.
Yeah. Pati, she's my associate consultant. And she's also doing the IAP Oncocritical Care Fellowship Program. Her topic is From Latency to Lethality, Adenovirus and Transplant Setting. Over to you, Swati. You can share.
Am I audible, ma'am?
Yeah, you can be a little
Okay.
louder, but yeah, you are audible.
Just a minute. Is it visible, ma'am?
Yes, you can go to full screen mode.
I think
Anything?
it's in the full screen mode, but
Okay, now it's not shared. You'll have to share again. Yeah, that's now it's better.
the entire presentation is visible, ma'am.
No, it is still in that small thing. Yeah, you have to click there's a one in the right, no?
I did,
I can
but
see that down. Yeah.
no, ma'am.
Yeah, perfect.
Okay, so good evening, everyone. I'm Dr. Swati. So we'll be discussing a case of adenovirus post-transplant that we had managed in a PICU. So this is a 5-year-old boy. At 1.5 years of age, he presented with ITP, and at that time, his bone marrow showed moderate aplasia of all cell lines. He was medically treated and off immunosuppressants for about 6 months and doing well till 4 years of age. And then at 5 years of age, he had an episode of URI, following which he had refractory aplastic anemia, for which he had undergone BMT with us. So during the BMT, these were the issues that he had. It was a haplo transplant from his mother with post-transplant cyclophosphamide. There was minor ABO incompatibility. There was ATG-induced hypertension, some gut mucositis, some CRS, which was managed with anakinra, and then during the engraftment also, which required methylprednisolone and 1 dose of anakinra. And towards the end of his engraftment, he developed asymptomatic tacrolimus toxicity. So by day plus 27, his tacrolimus was stopped because of toxicity. But then he had some mild dysuria, for which a urine panel showed BK virus up to 12 crore copies. He was started on cidofovir for this. And then on day plus 29, on his routine BMT viral monitoring tests, he was found to have adenovirus reactivation. Counts were about 5,000. And cidofovir was continued for him. He required admission on day plus 37 for low-grade fever spikes. So he presented with increased respiratory rate, but there was no distress, and his heart rate was like disproportionately higher compared to the temperature that he had. So at this point of time, the differentials that we had were a worsening of the previous adenoviremia, a new onset respiratory infection, or a cardiac decompensation or idiopathic pneumonia syndrome. So from the ER, blood cultures were sent. He was started on IV antibiotics and IV fluids. So to distinguish between all these differential diagnoses, we had done the following tests. So TRIVIS is a panel of three treatable viruses that we do in a hospital, including the COVID, the influenza, and the RSV. None of these three were detected. The blood culture had showed no growth. The CT chest was a normal study. His CBC showed pancytopenia. By day plus 41, his fever was increasing. We thought it might be due to ABO mismatch related hemolysis. And he had this new onset skin lesions, which you can see in this picture over here. So we thought it was probably GVHD because he had adenovirus. He was not on any immunosuppressive drugs. So low dose steroids at about 1 mg per kg per day of prednisolone was started for this, suspecting skin GVHD. But then by 3 days itself on this low dose steroids, his adenovirus copies had become 4 lakhs. So we again had to stop the steroids. We gave him a dose of IVIG and continued him on cidofovir. On day plus 49, he required PICU admission for respiratory distress. So at the time of admission into the PICU, he was found to have respiratory distress in the form of nasal flaring, and the disproportionate tachycardia was still persisting. So respiratory-wise, a chest X-ray was done. The lung ultrasound showed multiple B lines, and he was started on HFNC for the distress. For the tachycardia, the POCUS was done. It showed some mild LV dysfunction. He was started on levosimendan and low-dose Lasix infusion for the same. So at this point of time, our differential diagnoses were maybe adenoviral pneumonitis or myocarditis or some pulmonary edema or fluid overload or a new onset sepsis. So considering all these differentials, he was managed on these lines. To rule out myocarditis, we had done an ECG which did not show any features of myocarditis. The chest X-ray showed diffuse bilateral infiltrates, and the blood gas was normal. He had normal bicarbs, normal CO2s, and normal PO2s. But by day plus 51, he had these continuous high-grade fever spikes of up to 105 degrees Fahrenheit, which was not at all touching the baseline. There was persisting pancytopenia. His ferritin was increasing from 28,000 to 42,000. Again, we had to consider the diagnosis of sepsis, and antibiotics were upgraded after taking blood cultures. He also started developing shock and acidosis. We can see that the bicarbs have come down, and then the pancytopenia has worsened from before, and his ferritin had also jumped. So if anyone can just type in the comments, what will you suspect at this point of time? Because we were having a clinical suspicion of HLH at this point of time. He had this tachycardia and the tachypnea at this point of time. Slowly, his blood pressure started dropping. We had to start him on injection adrenaline and then later on noradrenaline. So we thought of adenovirus-associated HLH, but it was progressing to multi-organ dysfunction. At this point of time, we were really confused because if it is HLH, we need to give him immunosuppression. But then if it is only disseminated adenovirus, then the immunosuppression is going to worsen the primary disease itself. So we took the plunge and we went ahead with treatment of HLH. We gave him Solumetol at 2 mg per kg per day and gave him Anakinra at 2 mg per kg IV TDS. And for the adenovirus, we had continued him on Cidofovir. So after the management of the HLH, we can see that the heart rate has also significantly reduced. He was off inotropes. His respiratory rate was back to normal, and then his blood pressures were also good. His ferritin had also come down significantly. We can see this graph over here, but he did continue to have adenoviremia. So this was clearly a HLH which was triggered by disseminated adenoviremia, and we ended up treating it correctly. So brief talk on adenoviremia. So the risk factors for adenovirus reactivation post-transplant are if it is an allo-Hsct, especially with T-cell depletion done either in vivo or ex vivo, whenever there is severe lymphopenia, when the graft is taken from an unrelated donor, severe GVHD of grade 3 or higher, and if they've received T-cell depleting therapies like alemtuzumab or ATG. So in our kit, the T and B markers done by flow cytometry showed severe lymphopenia so low that even the subset analysis could not be done. So he was at a very high risk of adenovirus. So adenovirus, if not treated properly, can cause up to 70% mortality rates. And the increased risk of mortality is seen in conditions of disseminated disease when it is associated with multi-organ dysfunction. If there is prolonged viremia, when they have earlier reactivation with the virus, or if there is a CMV co-infection when the children are frail, or there is poor T-cell reconstitution. In a multi-center study, including our hospital, CMC Vellore and CMC Ludhiana, we found that the requirement for respiratory support, lower lymphocyte counts, and adenoviremia less than 100 days post-transplant were the factors associated with the highest risk of mortality. So monitoring-wise, usually adenoviremia post-transplant occurs from reactivation from the gut epithelial cells. Whenever there is more than one risk factor, as we have seen previously, a weekly PCR is done on the blood till immune reconstitution up till day plus 100. The PCR can be done either through peripheral blood or through other body fluids. And adenoviremia is defined as more than 1,000 copies in the PCR. There is probable adenoviremia, definitive adenoviremia, and disseminated disease. The main difference between the probable and the definitive one is histopathological. In definitive, you have a histopathological confirmation. And disseminated disease is when this histopathological confirmation is present in more than 2 organ systems. So the symptoms could be asymptomatic, respiratory with pneumonitis, gastrointestinal myocarditis, encephalitis, cystitis, might be disseminated and associated with multi-organ dysfunction. So the mainstay of treatment is to reduce the immunosuppression, which we had done in our patient. He was off immunosuppressant since the initial period of time, but we had to restart some immunosuppression because there were features of skin GVHD. And generally, if there are less than 10 copies and if the T-cell counts are normal, they have a spontaneous resolution of the disease. So what we faced in our case that I have described over here is the balance that we have to find between infections and GVHD. So once we are treating infections, we increase the risk of GVHD. And once we are treating GVHD, we risk the infections. So just the 3 days therapy with 1 mg per kg of prednisolone had increased his adenoviral copies so much that they had to, they caused HLH. So the main therapy that we have right now for adenovirus is Cidofovir. So Cidofovir has nephrotoxicity, and to reduce this nephrotoxicity, it is given along with hyperhydration and with probenecid. The usual dose is about 5 mg per kg given every week, but then you can also give it as 1 mg per kg thrice a week associated with hyperhydration and probenecid. Brincidofovir is also come, which is an oral counterpart of Cidofovir. It is said to have a lot of GI toxicity. Ribavirin is preferred only in species C of adenovirus. Ganciclovir and foscarnet have no evidence right now. The mainstay of therapy for refractory adenoviral disease is cellular therapy. So in case we were able to extract the memory T cells during the stem cell collection, we give these in separate aliquots post engraftment to help in immune reconstitution. Then there are also these specific virus-specific T cells. Here we can see something which was given for CMV virus in one of our patients. Similarly, we can have these interferon gamma enriched T lymphocytes specifically engineered towards adenovirus. Prevention is by contact isolation and through cohorted nursing. It's important to remember that adenovirus is very resistant to disinfection. So hand washing is mandatory after handling the patient, and then all the surfaces need to be cleaned with bleach wipes. So the take-home message is that vigilance saves lives. We are always having this delicate dance between infections and GVHD. We need to preempt complications and treat them early, especially in our children who are very fragile and can go downhill really quickly. Cellular therapy is here to stay and is the definitive therapy for refractory cases such as this. So, thank you.
Thank you, Swati. Great presentation. You can stop sharing.
Okay.
Any comments from Chris, our panelist, Dr. Ibor, Shashi,
Dr.
Rafi?
Swati, nicely presented and managed well. But I thought that the features were very clear for a disseminated adenoviral disease, right? Initially,
Yes, sir.
And the GVHD was a suspected or a biopsy proven?
No, sir, it wasn't biopsy proven.
But we have to start the steroids, before we are balancing between the infection and GVHD.
Sir, especially because we were suspecting hemolysis also because of the minor ABO incompatibility. These two factors were there, which we couldn't explain at that point of time.
Sure. Another one question, you thought about myocarditis, you said, and there was only mild LV dysfunction, and we use levosimendan for.
Yes, sir. In our unit, we use levosimendan in children with cardiac dysfunction because of its longer half-life and its anti-cancer effect, basically. Because all our thalassemia kids usually end up with cardiac iron overload. They already have pre-existing cardiac dysfunction. So in that case, we end up giving them levosimendan as a prophylactic measure to prevent further cardiac worsening.
Dr. Indra, how commonly you use anakinra in these sort of patients?
Yes. So if it is, one is for CRS. So two indications we use anakinra. One is if it is a cytokine storm, which we will see in allo CRS, that is soon after the stem cells, the first 3 days, or before the PTCY, or during the engraftment. We used to use tocilizumab, but we realized, and Swati has a very nice paper which she has sent for the St. Jude's conference, where we've actually looked at data of tocilizumab, the previous cohort and current anakinra. There was more viral reactivation with the tocilizumab because it's a monoclonal antibody, long half-life because of its large molecular weight. Anakinra is not a monoclonal antibody, it's just against the IL-1 and short half-life. And we saw, them cytokine storms were dramatically responding to anakinra. So in our unit now, we use first-line anakinra. If they don't respond to 2 doses, then only we give toci. The other thing is if you have HLH, we prefer anakinra because it's the IL-1. So, and here this was a classic, adenovirus triggered HLH with a cytokine storm. So we gave anakinra.
Okay. So we have not used yet because our hematologists are not happy about anakinra. So
it works.
It
works and it is cheaper. It is much cheaper. So some of them only need that 1 dose, 2 per kilo, which is much cheaper than you opening that tocilizumab vial. That you're immune suppressed for a much longer time.
So you give the twice daily dose, like 100 mg.
So it's clinical. So if it's not like a standard charted thing. This child, if the child had worsened, maybe we would have to go up to toci or something, or given it more frequently. Mm.
Can I add here?
Yeah,
So,
sure.
basically, sir, it is related to your question. This child underwent PTCy platform. So it is haplo under PTCy platform. This is post-transplant cyclophosphamide platform. That is a kind of in vivo T cell depletion. So in that scenario, what happens is this post-transplant cyclophosphamide comes on day plus 3 and day plus 5. So usually these patients post-transplant, because of the alloreactive T cells, they develop CRS on day 2, day plus 1, or day plus 2. So if that time, actually the need is those 2 days only you have to take care. Day plus 1, day plus 2, you have to take care. Day plus 3, anyway, cyclophosphamide is going to come. So that is the biggest reason why we can consider anakinra, because anyway you can give 1 or 2 doses of anakinra. Day plus 3, you will end up in giving cyclophosphamide as per the platform. So cyclophosphamide itself will cut down your cytokine storm. So it is basically, if you end up in giving tocilizumab as a long-acting drug, which is relatively not so necessary, because your cyclophosphamide is going to come on day plus 3 and it is going to take care of the action. So in that case scenario, anakinra being a preferred drug, and even in that secondary HLH scenario, which you got in later, adenovirus related HLH, there is no way we can prove. We all know that there is always a debate whether it is a HLH or it is a cytokine storm or it is a hyperphagocytic mods. You can put any terminology as per your wish, but the pathophysiology is same. So in that case scenario also, actually speaking, this choice is good. Usually we end up in giving 30 milligram per kg MPS and we wait for a few days, which we have been doing maybe 10 years back. But we understood that 30 milligram per kg MPS is not really having a huge evidence base. And even if we reduce it to 20 milligram, that itself is too much. So we give anakinra along with the 2 milligram per kg MPS, which is completely okay. So that anakinra would be able to take care of that HLH part without huge prolonged immunosuppression. So these two things we have to consider, and there are two, like maybe an additional, I would say more like a comments. You told about
how long you give? You'll give it as a full course?
Sir, anakinra, actually we currently have one patient who's receiving anakinra for last 75 days. Anakin 75 days. The issue is different.
We thought we are bad.
So I think we are going to arrange canakinumab, because we cannot. Canakinumab is once in 30 days. So because that is a very different scenario. It is a immunosuppressed child. It is a Sogia with a macrophage activation syndrome. It is a relentless macrophage activation. Went in for renal failure. He has become dialysis dependent. The thing which we have never expected happened is he was dialysis dependent for 2.5 months, and then he has become dialysis independent on anakinra, and his creatinine went to 0.7 from 6.5. So, so anakinra usage has, why I'm telling this case is, anakinra usage has increased a lot. But saying so, long-term IL-1 receptor blockage related side effects, we really do not know. So that is why it is not advisable to give a longer duration anakinra. In secondary HLH cases, most of the time we end up in giving 5 to 7 days max. So usually we say in the dengue HLH and all, we will give maximum 6 to 8 doses. 6 to 8 doses means 2 milligram per kg per dose, 3 doses day 1, 3 doses day 2, and day 3, 1 or 2 doses, then we stop. Some patients will have recurrence of hyperferritinemia. The liver function may deteriorate. So because anakinra is ultra short acting, so that's the problem. So later you may end up in restarting anakinra. That may happen. But the worst case scenario, you may require 10 days, not more than that. The other thing which I want to
you
tell,
stop using tocilizumab at all. Tocilizumab you're not using it.
Tocilizumab better to avoid as far as possible, sir. Because even
reserve Brahmastra.
Basically, this is a post-haplo scenario. Even if you see CRS guidelines, which we borrow and use in this scenario, like cell therapy guidelines, like CAR-T CRS guidelines, they will say first line itself is tocilizumab. But there, the scenario is something completely different. It is going to be relentless CRS. But here you have PTSI, which is on day plus 3, day plus 4 or 5. So that will come and take its action. So post haplo, this PTCY platform haplo, giving tocilizumab is little too much. That is why we are more happy with Anakinra nowadays. And another thing about this memory T cell add back, it is a very good thing, but it is commonly used in alpha beta depleted TCR alpha beta depleted graft. So because there you collect and you deplete, 90% will go for TCR alpha beta depletion, 10% will go for memory T cell RA depletion and RO selection. So CD45 RO you will get 1 million cells, you will make 5 bags and you keep it and then use it. But in this scenario, like a PTSI platform, getting memory T cell later from the donor will become tough. So most of the time we end up in treating without cell therapy, without memory T cell add back, because that's a realistic scenario.
So
And
we use a lot of memory T cells, our hematooncologists. So the CD4 is low on they check on days 30 and then again day 100. If that is low, then they give memory T cells.
Yes.
Now this child had adenovirus reactivation. Probably the anakinra that he got during the allo CRS and the engraftment CRS could have also, triggered that. So that is a cost that we pay. We don't know.
Yeah, this child has multiple reasons. And another thing is that's why people now feel TCR alpha beta depleted graft is better, because you have told about your risk factors. You have enlisted both together. TCL, that is TCR alpha beta depletion as well as a risk factor, and PTCY as well as a risk factor. So you have to differentiate this. So PTCY platform is a big risk factor for viremia, because your CD4 count during day plus 30, that is the immune reconstitution, is going to happen a little slower. So you have a higher risk of viremia. But alpha beta depleted graft, TCR alpha beta depleted graft, you may have graft engraftment issue. That's a different story. But your issue of viremia is relatively less. So viremia, when you say viremia risk, always the problem is PTCY platform, viremia risk is that is the price we pay for reducing the GVH. So
but the price for the alpha beta depletion is also vast. It's about 12 lakhs compared to the cyclophosphamide, which is nothing.
So that part we have to be very careful. And whenever two viral reactivation happens, it becomes very, very difficult. Here, the only good thing is BK virus and this both the Cidofovir is a therapy. But only thing is whenever you have this kind of viral activation, that 1 milligram per kg dose, 0.5 to 1 milligram per kg dose thrice in a week for 2 to 4 consecutive weeks. That will function little better even without probenecid. It is fine. So if you are using creatinine follow-up, GFR follow-up, if GFR is more than 80, 85, then you can comfortably use that. Yes.
Thank you. We'll move on to the next case, Dr. Abhinaya. She has finished our course, Transplant Critical Care, with us, and she's now working as consultant RELA.
Oh, so
Dr.
Swati is also a transplant critical care fellow? Or?
She's an associate consultant, my associate, and also doing this IAP Onco Critical Care, which IAP, as you have started this year. This year, yes. Abhinaya, over to you. Yeah, your slide is well visible. Good.
Thank you, ma'am.
There's some echo. You want to switch off the other phone or you? Yeah.
How about now?
It's still there. I think you've got two.
Yeah, you probably are in two instruments. One you have to switch off.
Yeah, one you'll have to log off from one. So Dr. Abhinaya finished her DM critical care, and then she joined us for the transplant critical care fellowship. You okay, Abhinaya? Abhinay, you there?
How about now, ma'am?
Yeah, clear. Go ahead.
Yeah,
My slides are visible, ma'am.
Yes, yes.
yeah, it is.
Good evening, everyone. Today, I'm here to present a case story of an infant who presented to us at 8 months of age. He's a male kid. He is symptomatic from 6 months of age in the form of blood and stools as his first complaint. And he also had Salmonella typhimurium in blood culture at 7 months of age, and followed by recurrent respiratory infection. And at 8 months of age, he had high CRP with persistent fever spikes, and he was referred to our center. And in our center, we found that he is having the axillary lymph node with hepatosplenomegaly, and he also had a pneumonia. We can see the baby working very hard, but even then, when he was on HFNC, and this chest X-ray showed right upper and middle lobe pneumonia, dense consolidation. Later on, he developed nodular skin lesions also. So with this history, what would one suspect? So we have this Jeffrey model for identifying primary immunodeficiency. 10 warning signs are given, and our index child had 6 warning signs positive for primary immunodeficiency. So you can see the CT, which showed solid subpleural as well as parenchymal nodules to form dense lobular consolidation with bronchial thickening, and also diffuse ground glass opacities we can find in the left side of the CT chest. So the right side is completely involved, and the disease is also progressing to the left side. BAL galactomannan was positive. We isolated pan-sensitive Burkholderia cenocapacia from skin nodule as well as BAL. You can see the sensitivity report given here. And he stayed with us for more than 45 days. He received sensitive antibiotics for more than 3 weeks. Celebrated his first birthday in Piku also. But even then, his infection was not clearing, and he was having dense consolidation. He progressed to get intubated, and we can see the peak pressures, which was 22, requiring PEEP of 7, FiO2 of 40% on day 23 of hospital stay, which means we have given him sensitive antibiotics for the past 23 days, but still we are not able to clear this dense consolidation and infection. So due to this persistent pneumonia, as well as we identified only Burkholderia cenocapacia, even on sensitive antibiotics, he has not cleared his infection. So we went ahead to do a needle biopsy of the lung, which is done at the bedside here by in IR team. Child was intubated, and BAL was also repeated. So post all these procedures, on day 27, he worsened to have increased peak pressures. He was receiving a PEEP of 15 with 100% FiO2. He was receiving INO4 pulmonary hypertension, but still he's fighting this resistant Burkholderia. So needle biopsy showed granulomas with the necrosis and abscesses. Again, we had pan-sensitive Burkholderia, but there was no nocardia, and fungal PCR was negative. We did the PCR on BAL as well as in right lung biopsy, which was negative for Aspergillus, but gram stain also showed there is no bacteria. So we have a complex pathogenic matrix. We have this persistent Burkholderia cenocapacia, which is growing in BAL, needle biopsy of the lung, and skin abscesses even after multiple sensitive antibiotic treatment. We have this mycobacterial, which was identified. We identified BCG, BCG from axillary lymph node. He had this lung consolidation with hepatosplenomegaly, which qualifies for disseminated BCGosis. So he was also on 4-drug ATT. And viral panel, respiratory viral panel showed enterovirus and rhinovirus positive, CMV reactivation, and due to galactomannan positivity, there is a suspicion of probable invasive fungal infection, for which he was on IV amphotericin and ganciclovir. Despite all these things, we had this persistent dense consolidation. He was also positive for DHR, dihydrorhodamine test. There was absent oxidative burst reaction, and then whole exome sequencing showed positivity for chronic granulomatous disease. And we can see the CPC showing 46,740 of WBC count, but still the dense consolidation persisted, which means that the WBCs that we have is not able to clear the infection as well as it is defective. So we went ahead and gave Buffycoat infusion, which we are trying to eradicate the infection using normal neutrophils and granulocytes. We went ahead and gave like around 9 sittings of Buffycoat transfusion along with IVIG infusion. So from this dense consolidation, we were able to clear the infection. However, we can see the chronic lung changes, which is shown in the X-ray. And then we proceeded for hematopoietic stem cell transplant. So why do we do hematopoietic stem cell transplant in such a difficult case who has persistent Burkholderia positivity, and we are not able to relieve him from his infection because his family was desperate. He was the only child who was conceived after 8 years of marriage through IVF, and we pushed to a corner because from the age of 6 months he has never given a window for us to proceed for hematopoietic stem cell transplant. Now we have that window. We have the chronic lung changes with negative septic markers. So we proceeded to gave him a chance for hematopoietic stem cell transplant. So we started the conditioning regimen, but however, he developed a new onset fever spikes on day 4 of conditioning, increasing ventilator settings, hemodynamic instability, escalation of antibiotics. Finally, he succumbed to illness on day -2. And post-mortem cultures, all the cultures showed positivity for Burkholderia. So we have ARDS, which is progressive, refractory shock, which is both septic and cardiogenic, pulmonary hypertension due to the infection and resistance that is produced due to ARDS, persistent Burkholderia cenocepacia, which is growing from lung, blood, and everywhere, disseminated BCGosis, and an underlying diagnosis of chronic granulomatous disease. So the take-home message is uncommon bugs, disseminated BCGosis, always suspect inborn error of immunity. The name has been changed from primary immunodeficiency to inborn error of immunity. Early identification of unusual bugs. So we have to be very vigilant and we have to keep on screening. Do all the investigation promptly and identify the bug to eradicate the bug. It is vital for survival in immunocompromised patient. So combination antibiotics. One antibiotic doesn't work in these kids because the penetration is very difficult. Granuloma is very thick and the bacteria is very resistant. Also, the Burkholderia produces a slimy layer around it and it sits inside a granuloma, difficult for the antibiotic to enter into and kill them. So we always have to involve microbiology and infectious diseases specialty, make form a plan and then proceed. Early Hsct in inborn error of immunity before the infection become refractory to treatment will help in survival. Thank you.
Thanks, Abhinaya. Thank you.
Thank
Good
you.
presentation. Thank you. Thank you. You can stop sharing.
Okay.
So this was we have never attempted Hsct on a ventilated tracheostomized child, to be honest. This was the first time. We were pushed against the wall and there was really no window. I think the problem with CGD is they look really well. And though some pediatrician had diagnosed, they went, doctor shopping. They did not do the blood test. Somebody had suspected immune deficiency when the child had salmonella. But, these things happen. It was more denial. And by the time, Burkholderia was picked up in the bowel and think it was too late. That wouldn't go. So it's so crucial to get that period before they have something resistant, which, before they have lung and pneumonia, Burkholderia, it just sits there in the lung and refuses to go. It was pan sensitive till the last culture. 24 hours before death, we did the blood culture. Only that was resistant. Till then, it was only pan sensitive Burkholderia. It just goes to show that how useless those neutrophils are. Even though they were almost 50,000. Yeah.
Was there a fungal infection as well, right?
There
For
was
this
only
patient? Or no?
galactomannan positive, but we have never isolated. But because the child had symptomatic, we did give amphotericin and posaconazole for a long time. This was just
Sure.
learning, and yeah, we had to
So,
support the family. The child was otherwise, but we could not let go also. So anyway,
yeah, in
go
spite
on.
of severe infection, our experience also is quite bad.
Yeah.
Yeah, but you do normally this, you have done a BAL and isolated, and still you did the lung biopsy.
So we did the BAL before the child was went. So child had worsened in another hospital. And then they had done the BAL, sent the culture that got Burkholderia. The minute they had this unusual bug, and then they sent the bloods also, and then sent to us. Now we treated with the appropriate antibiotics. 3 weeks, child did not improve. And then the child started worsening. Now we can't take up for transplant. You have a bad, it's spreading to the next lung. So we told the family that is another dilemma. The families, we tell them if the child we go for BAL, child will get intubated, may not come out of the ventilator. Then they don't want the BAL because, they were worried, no, might as well continue. It's sensitive. So, a few days go. Then we just did it. And in the same setting, I think the BAL was negative again. BAL was negative second time. So we did a lung biopsy.
Madam,
To find out if there's any other bug, because we have had a child who we had, it was a JMML child with a mass in the lung. Everybody thought it would be the malignancy, leukemia itself. Turned out to be mucor. Child is otherwise fine, no oxygen requirement, nothing, just one nodule there, and turned out to be mucor. So luckily we could, discuss about, removing the mucor before taking up for transplant. In the chat question, I saw one question about surgical. It was discussed whether we should remove the lobe itself, but by then it had already spread. Yeah, that discussion was there. Lobectomy, because you're having resistant Burkholderia. I mean, you have a stubborn Burkholderia.
Most of the time, actually, this approach looks for the people, fellows who are listening to the program. The very important message would be most of the time it would be the best decision to do the needle lung biopsy because these are all the patients like CGD where there is a phagocytic defect. These patients are going to harbor multiple organisms. If the basic rule is if you find one organism, don't be very happy that you found the organism. So you are having multiple organisms as bystanders, or the organism you found may be a simple bystander. There are so many other culprits who are remaining. So most of the time, Aspergillus and Nocardia cannot be ruled out simply by just taking a ball sample. And these are all like the organism which will be embedded inside the granuloma or in the cavity. So when you are taking a bronchoscopic ball sample, most of the time you may not be able to find these organisms. So the finding Nocardia and Aspergillus is unlikely to happen, especially in these small kids. So in that case, maybe this is the best scenario to get the needle biopsy done. Yeah. So that is one. And second thing is about the bees.
Could the
About the
others
bees.
mute themselves?
Yeah. About the BCGiosis, if you are thinking of Mycobacterium bovis, Dr. Abhinaya, do you really think that HRZD is required, or what will you do?
So we gave levofloxacin, right?
Yes, sir.
Yeah. So that's okay, but the pyrazinamide is inherently resistant. So usually pyrazinamide is of no use in BCGiosis patients. So you add levoflox, but pyrazinamide can very well be avoided because it is inherently resistant. Your Mycobacterium bovis is going to be inherently resistant. Yeah, levoflox add, but don't make it HRZD because that has an additional advantage because the polytherapy is rule for these patients. So as far as possible, whichever drug you can reduce, that's better. And another question to Dr. Abhinaya. So do you think that the
Sir,
Buffy coat, what is the problem in Buffy coat, especially in this patient?
sir,
Why you
CMV
cannot give Buffy coat?
reactivation, CMV
Okay.
reactivation one,
Anything else? Anything
and
else?
then it causes worsening of ARDS
Raleigh.
Yes.
when it is given,
Especially in this patient.
That was
especially.
we
Yeah.
thought of that. So we didn't give granulocytes, but we gave Buffy coat. We
Yeah.
had no other go. We were prepared to intubate anyway. It
Yes.
was, we're fighting. We knew we were fighting a losing battle, but actually, child tolerated the Buffy coat
Yeah.
all along in the ward. So we
And,
got some
so
nice sessions.
one point here is you are by exposing to Buffy coat, you are creating an allo immunization. So
Yes, sir,
if you are going to say that it's a prospective BMT patient, then every Buffy coat exposure is going to be an allo immunization. So then you may struggle with allo immunization later. So you have to be very careful about pre or peri-transplant Buffy coat, especially.
I think this child, the priority was getting the infection out.
Yes.
And
Yes,
the
ma'am.
other thing with Buffy coat is also CMV. So this child
Yeah.
CMV went up after with the Buffy coat. So
Yes.
there was
That
rise, and
is expected. Yes.
we had to put ganciclovir. That's another
Yes.
risk with Buffy coat. So we
Yes.
now move to the next case, Dr. Milind. He is now consultant at Rainbow in Bangalore. He finished his transplant IAP critical care fellowship with us last year. Dr. Milind, you can share your slide.
He was your first fellow, right?
Second, Dr. Eber, second batch. Rachit was first.
Is it visible
Yeah.
now?
Yeah, visible. You
Okay.
can be a little louder. Yeah, sure.
Okay. Yeah. So, good evening, everyone. So today I'll be discussing a challenging case in pediatric hematooncology care. So with the topic, when the mediastinum strikes the heart, a tamponade story. So this is about 11-year, 7-month-old boy with no major primary comorbidity who presented with chronic respiratory symptoms. So in the month of May, he presented to an outside hospital with breathing difficulty and productive cough for 2 months, and also with symptoms of fever, chills, sweating, and reduced appetite for 2 months. His CBC was within normal range, and AFP and beta HCG were normal. But the chest CT done there showed significant cardiac compression with a retrosternal anterior mediastinal mass with query teratoma. So here we can see that there are three red flag signs. There is persistent respiratory symptoms, constitutional symptoms like fever, chills, sweating, and reduced appetite, and also imaging showing significant cardiac compression. So we can immediately place this child in a potentially high risk category. So following this, the child was brought to Apollo Cancer Center in the month of December after 6 months as the symptoms persisted for further evaluation and management. So at admission, child was alert, had mild tachypnea, and child was pale. Airway was maintainable. Child had a respiratory rate of 30 with the right-sided air entry being reduced, and there is no increased work of breathing, but saturation on room air was 65%. And after starting 5 liters of mask O2, the saturation improved to 92%. On terms of hemodynamics, the hemodynamics were maintained with heart rate of 120, BP of 100 by 60, CFT of less than 3 seconds, and peripheral pulses were verified. With the neurologically everything being intact, and exposure-wise, child had mild periorbital puffiness. So here we can see that despite having hypoxemia, child was still compensating hemodynamically. So, and also the blood gas, you can see that it importantly shows uh, does not show any severe acidosis or hypercarbia, suggesting a compensated physiology happening at this stage. So our impression at this stage was respiratory distress with hypoxemia and child being hemodynamically stable. This was the chest X-ray which was done at admission, which shows left-sided pleural effusion with underlying collapse, homogeneous opacity in the right perihilar region with massive cardiomegaly with mediastinal widening. So child was admitted on the 2nd of December and relevant investigations were done. CBC wise, everything was normal with tumor markers showing mild elevation in the beta HCG and alpha fetoprotein, and screening echo at admission showing good LV function with ejection fraction of 58%. Significant pericardial effusion was noted, but there is no chamber collapse. So at this stage, child had significant effusion and no chamber collapse. So this meant that there was preserved ventricular function and the cardiac output were maintained. So some people might ask that why we have not drained the effusion as it was significant effusion, because we didn't have any evidence of tamponade here as there was no chamber collapse, EF was preserved, and also hemodynamically stable child. So we the immediate invasive drainage was not indicated here. So we had planned for an anterior mediastinal mass biopsy here. So the next high risk phase for us comes in mediastinal mass biopsy, where this is here you can see the image where we have done mediastinal mass biopsy there. So what is the issues in this condition is the sedation and the general anesthesia will be dangerous in this phase because it's a condition of can intubate and cannot ventilate situation where the mass can compress the trachea and the right ventricular simultaneously, and deep sedation can cause loss of muscle tone, causing complete airway collapse. And also, if you are intubating the child electively or giving any positive pressure ventilation, it can further compress the right ventricle, causing decrease in the venous return, decrease cardiac output, and eventually leading to cardiac arrest. So what we did in this situation was using only mild sedation, where we used sedation only to calm the child and not to sedate the child per se. And we made sure that spontaneous respiration was maintained throughout the procedure. We used agent like ketamine, which usually preserves the airway tone, preserves spontaneous breathing, and the sympathetic drive is better with ketamine compared to other induction agents. And it was performed in a very safe environment as PICU with full resuscitation team on standby. Anesthetist and PICU intensivist were all present in during the procedure, and cardiac CTVS surgeon backup was also informed and it was present. The biopsy was done under ultrasound guidance, which was quick, precise, and minimal anesthesia time. So biopsy confirmed immature teratoma, and histopathologically it was shown to have predominantly mature teratoma with rare immature neuroepithelial tissue, and a final diagnosis of anterior mediastinal immature teratoma was made. So child was continued on 5 liters of oxygen, IV fluids, ceftriaxone, sulbactam, and teicoplanin was added for the pneumonia. And child was started on injection DEXA, and anti-tumor lysis prophylaxis was initiated. Child was also started on JAB chemotherapy, that is jarboplastin, etoposide, and bleomycin chemotherapy. And we noted subtle hemodynamic deterioration here. So here in this via a monitor, we can see that there is in the plethysmographic waveform of the saturation, we can note that there is pulsus paradoxus. So it is the earliest sign which we noted even before we noted there was hypotension in this patient. So following that, we also noted that there was hypotension for which we had given fluid boluses just so that the preload is optimized, and also NORAD was started. Maximum we had gone up to 0.3 mics of noradrenaline. And screening echo was done that time, which showed significant effusion with collapsed cardiac chamber. So here on echo, you can see the images where there is a significant pericardial effusion, where on quantifying it on the right ventricular posterior side, it was 2.2 centimeter, and on the right ventricular posterior, it was 2.6. So anything more than 2 centimeter is termed as a large effusion. And also on the other image, you can see that the mass is compressing on the RA, and there is still fluid around. And eventually, if the mass increases, then it might compress on the RV too. Also, on the clinical aspect, the heart rate still remained to be high. The BP showed high diastoles with narrow pulse pressure, which shows that there was some pressure on the right ventricle happening. And also, the oxygen dependency was still persistent. So, looking at the plethysmographic waveform, we found that there was saturation which was maintaining, which was 97%. The number looked normal, but the waveform was abnormal. You can see that the small peaks during the inspiration and during expiration, there were tall peaks present. So that means that there is some amount of hemodynamic compromise happening. The saturation is maintained because so SpO2 will usually measure the oxygen saturation and not the stroke volume or the cardiac output. And with every beat, there is some amount of oxygen which is being delivered. So the saturation is preserved, but during inspiration, it delivers less amount of blood, causing the waveform to be shrunk. So in the early tamponade, only the waveform is compromised, and this was the earliest sign what we noted in this child. And this happens mainly because of the ventricular interdependency. So during inspiration, there is negative intrathoracic pressure, so causing RV to fill more. But as there is pericardial fluid present, the total cardiac volume only is restricted. So when the RV fills, it pushes the septum to the opposite side, causing the LV volume to be less, so causing less LV output, reducing the stroke volume and reducing the systolic blood pressure during inspiration. So we discussed with the cardiologist and CTVS surgeon, and we had planned for a pigtail insertion. This is the image showing pigtail being in place for the child. And this is the X-ray which is showing pigtail in situ. So one more thing about recognizing cardiac tamponade is something called as a Beck's stride. So Beck's stride is what we feel is the more of a late marker for identifying cardiac tamponade. So it constitutes of three features, that is hypotension, the raised JVP, and muffled heart sound, in which we had hypotension and the muffled heart sound which is present. So in this case, we feel that the tamponade would have happened because the mass effect, which is directly compressing on the pericardium, or after initiation of the chemotherapy, there might be some tumor lysis happening, causing inflammatory fluid shifts and rapid tumor necrosis. So this is a video of the echo which was done after insertion after 5 days. So the oxygen requirement for the child had come down. Child was on 2 liters of nasal prongs oxygen. Screening echo showed collection was still present, but the cardiac contractility looked good. But the pigtail had around 75 to 90 ml of drainage every day. So however, this being a malignant and a proteinaceous collection, it behaved differently from a simple serous collection. So by day 12 of admission, child was again noted to have respiratory distress, requiring escalation of HFNC support, and also child being irritable and agitated. So at this point, the conservative drainage strategy had failed for us. And this is the repeat X-ray, which shows fluid being reaccumulated, and also the echo, screening echo, showing the fluid accumulation, the distance showing around 3.23 centimeter, which has significantly increased from prior. So on that day, we discussed with the cardiac surgeon and we went ahead with the surgery in view of persistent respiratory distress, recurrent fluid accumulation, and inadequate drainage. So emergency exploration for cardiac tamponade was done. Debulking of the mediastinal mass, that is the mediastinal tumor which was excised out, and a pleuropericardial window was created. And there were mediastinal and the pleural drains which were placed, and patient tolerated it well. So the pleuropericardial window usually allows continuous drainage of the pericardial fluid into the pleural space. So it reduces the recurrent tamponade risk. So this was the X-ray after 10 days, which showed no fluid or pericardial fluid collection or any cardiomegaly, with no pneumothorax after removal of the drains. And also echo showed good cardiac function with ejection fraction improving up to 60%. This is him after the drains were removed and he was mobilized. And so come to the discussion part. So the mediastinal immature teratoma is seen as 3% of all the pediatric germ cell tumors and less than 10% of the mediastinal teratomas. The immature type is mostly seen in the males, and it peaks during the first or second decade of life and usually present with fever, cough, and dyspnea. So the biggest learning for us is identifying of the cardiac tamponade. So if you have a stepwise approach to it, then it will be easy for us to identify. And the earliest clue here is not the hypotension. It is mainly the physiological changes, that is the plethysmographic waveform changes that happens. The next step will be to do a 2D echo and confirm and quantify the effusion. And the later changes will be the Beck's stride, which is the late sign along with hypotension present. And management of pericardial tamponade, initially a fluid bolus might be needed just to stabilize the preload so that you buy some time till you insert a pigtail catheter. And then next step is the pigtail catheter. And while inserting that, you should keep in mind that you should always use a large bore or an appropriate side drain, so that in malignant effusion, they're usually thick, loculated, or proteinaceous, and they usually block the small catheters. And if this fails, then the next phase is to go for emergency debulking and pleuropericardial window. So the key learning points from this case was that the mediastinal mass in any child with unexplained respiratory distress, we need to always do a screening echo early to detect for any pericardial effusion. The proteinaceous tumor-rich debris with rich malignant effusion can have rapidly blocked the small bore pigtail catheters. The cardiac tamponade from a mediastinal mass is a surgical emergency. When pigtail fail, we should not delay. We should go ahead with emergency debulking and pleuropericardial window, which is life-saving. The JEB chemotherapy, which is from the Children Cancers and Leukemia Group Protocol, is a standard neoadjuvant therapy. Post-chemotherapy, tumor lysis can also worsen the effusion, so you need to anticipate and monitor for it. And multidisciplinary team approach with pediatric oncologist, intensivist, intervention cardiologist, and CPVS surgeon is always prefer to save lives. Thank you.
Thank you, Milind. Good presentation. You can stop sharing.
Yeah, it's an excellent ICU case, right? With the scary anterior mediastinal mass with a high-risk airway management. Nicely presented, Milind. As you asked the question why it was not drained, and I will also ask you the same. And why it's a massive pericardial effusion, right?
Yes, sir.
We did a biopsy and it was nicely done with ultrasound. Ketamine is a well-established drug for preserving the respiratory drive as well as the airway tone. That is what is very important here. And why we didn't do it? Because there was no tamponade effect.
Yes. Yes, because they had started the chemo. They were planning to start, and usually awaiting steroids, if it is a lymphoma and all, it will be very sensitive. It just shrinks.
Yeah, it melts
And,
like
the effusion also gets resolved. Only that we got, all the diagnosis and the effusion started increasing. Yeah, we didn't tap because there's risk of infection. When you put a drain in the heart, pericardium, and you start your chemo, there is high risk of infection. So unless there was tamponade, we didn't want to drain it.
Yeah, it is good. It's clearly you anticipated it and the early signs were found. And you have all the multidiscipline involved.
Actually, this child had effusion for a long time, was stable. Only after we started the chemo, the drugs, then the child worsened. So that was...
Did we do a CT scan anytime earlier?
We
At
did.
least, did we?
Yeah, we did. No, Milind, you showed the...
It's done outside, ma'am. We have
outside.
not
Yeah,
done
they brought the images.
So you can tell for others, when you are tubing the patient, what sort of a tube was used and how was the anesthetist be prepared? Did we have a ECMO backup later when he did the surgery? Milind?
Yes, sir. We did have CTVS backup with us. And as the ECMO backup might have been required if the child had any arrest or deterioration.
Usually they use the reinforced tube, right?
Yes,
For what sort of help it might
So
be.
the first biopsy was done without any intubation, just with sedation.
I know that.
If you had seen that, the child was semi-propped. Was semi-propped. And after that, it was done in the OT, cardiac OT. So with the bypass itself standby. So they could go for bypass itself. We are not sure what type of ET tube they did use. Usually reinforced so that the airways...
usually will reinforce. Even with that, we will struggle. It is not about, he has mentioned clearly about can intubate, cannot ventilate because of compression. It's a scary situation. Yes, we do all.
It is very
so we'll move to the next case so we can rapidly wind up. Yeah, Ria. So it's not a case, it's basically experience for those who don't know about ECP. Ria, can you share your slides?
ECP, no, extracorporeal.
Extracorporeal cytophotopheresis. Yeah. Ria is here.
Is it visible, ma'am?
No, not yet. Not yet. Yeah. You can put in full screen. Yeah.
Is it visible now, ma'am?
Visible. You can talk louder.
Okay. Good evening, everyone. My name is Dr. Ria, and I will be presenting on extracorporeal cytophotopheresis, a game changer. Coming to the definition, ECP is an immunomodulatory apheresis procedure where the leukocytes are collected, exposed to 8-methoxysorolin and UVA light to induce apoptosis. They are then reinfused to promote immune tolerance. Historical background, ECP was developed in the 1980s for cutaneous T-cell lymphoma, as you can see in the picture. It's based on PUVA therapy, which is sorolin plus UVA light, which is used in dermatology, especially for vitiligo patients. The clinicians then realized it modulates the immune response and not just kills the malignant cells. Hence, it has been expanded to graft versus host disease, transplant rejection, and other immune conditions.
Coming to the indications, according to the American Society for Apheresis, it's used in the transplant setting, especially in graft versus host disease, as a especially the steroid refractory acute and chronic GVHD as a second line treatment, as well as solid organ transplant rejection. Coming to acute GVHD, it is where the immunocompetent donor T lymphocytes mount an immune response against the recipient, and it mainly affects the skin, gut, and liver, as you can see in the pictures. Chronic GVHD, it manifests 100 days post the stem cell transplantation. It also affects the skin, gut, and liver, and the skin changes are more lichenoid and sclerotic, and it also affects other organs such as lung, musculoskeletal, and hematopoietic. It is also used in solid organ transplant rejection, particularly in lung transplant rejection, in especially bronchiolitis obliterans, and cardiac transplant rejection in selected cases, as an adjunct to reduce chronic rejection and immunosuppression burden. Coming to the procedure, we use the Spectra Optia apheresis system, and mainly the procedure gist is that we first do a white blood cell collection. There's addition of 8-methoxysorolin, a UVA exposition is done, and reinfusion of the treated cells to the patient. Next is the mechanism of action. So the first step is the apheresis, where we take the platelet RBCs and separate it from the T cells, and we reinfuse the platelet and RBCs back into the patient continuously. And then the T cells are exposed to the photosensitizing agent called sorolin, and then it is photoactivated with the UVA light. So then the pathogenic T cells get saturated by the dye and get destroyed. The activated T cells are then destroyed, and the non-pathogenic T cells are non-activated by and spared by the photosensitizer. The second stage is the T cells that are pathogenic get go into apoptosis. And the third step is that there's differentiation of the dendritic cells. The antigen presenting cells then ingest these apoptotic cells. Next is there is a T cell shift, where there's a decrease in the effector T cells and the increase in the regulatory T cells called TREGs. Last step is the cytokine shift, where there's an increase in the anti-inflammatory cytokines and a decrease in the pro-inflammatory cytokines. Thus, CCP effectively induces immune tolerance without generalized immunosuppression. Coming to the process in detail, first is blood collection. The patient's blood is drawn into the ECP machine, and leukapheresis is undergone by centrifugation. The buffy coat or WBCs are separated, and the RBCs and plasma are returned to the patient. The product is a T cell rich lymphocyte fraction. The anticoagulation that we use can be either citrate or heparin. In our center, we use citrate. Less than 20 kg, we do a priming with leukodepleted irradiated RBCs to avoid hemodilution. More than 20 kgs, we can use normoxanil. Next is leukapheresis. First, we have to, before the procedure, we have to take a CBC and ensure that the pre-ECP target is attained. The HB should be more than or equal to 8, total count more than or equal to 1000, and platelet more than or equal to 20,000. As you can see in the picture, the patient's CBC, the WBC count is 2.6 thousand, and the lymphocyte count is around 13%. But after the ECP procedure, the collection, we see that the WBC is around 30,000 and the lymphocyte is 46.9%. Next is the photoactivation step. We add the photosensitizing agent called 8-methoxysorolin. It makes the T cells sensitive to the UVA light, and the 8 MOPS treated WBCs are then exposed to the UVA light. This UVA light cross-links and damages the DNA of the T cells, and apoptosis or programmed cell death occurs. Next is reinfusion, where the UVA-treated WBCs are reinfused back into the patient. What are the advantages of ECP is that it's an immunomodulatory and not an immunosuppressive treatment. There's a decreased infection risk compared to steroids and biologicals, and there's minimal drop in counts. It's a steroid sparing effect and it's a safe treatment. It has a targeted effect on T cells, and there's no major systemic or organ toxicity, and there's no drug interactions. It can be combined with other therapies. As you can see in this picture, for the skin GVHD, after 2 cycles of ECP, the patient, the skin GVHD has rapidly improved. Next is the complications. Complications being the vascular access can lead to infection, thrombosis risk is there. Hemodynamic instability due to volume shifts can lead to hypotension. Photosensitivity also may be present due to the Sorrelin dye. So eye and skin protection from the sun is needed for at least 24 hours. Hematologically, platelet and RBC loss may be present and may need replacement products. In lung GVHD, there could be hypotension if pulmonary hypertension presents. In our center, we had a case of lung GVHD who during the ECP procedure had hypoxia and hypotension. So we had started noradrenaline, and afterwards the blood pressure had improved, and we had noticed that the saturation also improved with our hemodynamic stabilization. And we generally avoid prophylactic oxygen to prevent lung fibrosis post-busulfan. What are the other complications are sedation-related issues in children, and also anticoagulation related complications. For citrate, there could be hypocalcemia. That is why we take a BBG pre and post procedure and give any correction post procedure. Heparin also can lead to bleeding from the insertion site, and preferably this process is performed in the PICU setting. To the treatment protocols, so in acute GVHD, usually around 2 to 3 cycles per week, and then they taper it based on the response. And chronic GVHD around 1 cycle every 2 weeks and later monthly maintenance. But it essentially is individualized and depends on the response. How do we assess the response is through skin, liver, gut improvement, and are we able to come down on the steroid? Limitations is it is resource intensive, it requires specialized equipment and trained personnel, and it's costly, requiring repeated sessions as outpatient with sedation. Limited availability, it's not widely accessible, requires specialized centers. Our experience or institutional data, we have done 200 plus sessions in 5 years, around 90% response in chronic GVHD and around 60% response in acute GVHD. It is the most common post-stem cell transplant extracorporeal therapy at Apollo. And the best responses are seen in gut, skin, and musculoskeletal involvement. And early initiation has improved outcomes with significant steroid-sparing effect and good safety profile. However, hypotension is the most common complication encountered. Coming to the organ-specific outcomes, we have noted that in GVHD, they require around 3 to 8 sessions per patient. And in acute GVHD, as you can see in this picture, it was seen best response in gut and in skin with the 84% and skin of 72% response. However, it is having a poor response in severe acute GVHD. In chronic GVHD, in the below picture, it was shown a best response in mucocutaneous of around 71% response. And it's also effect in severe chronic GVHD, except for lung GVHD. In transplant rejection, we've used it in around 3 cases. One was for heart transplant rejection and 2 for lung. Next is a summary. GVHD can be very challenging and debilitating. Immunosuppressives for GVHD can lead to serious infection. ECP is a game-changing T-cell targeted immunomodulatory therapy. It causes no immunosuppression. Hence, it's better having a better response with early initiation. Thank you.
Thank you, Ria. Good presentation. Thank you. I can stop sharing. And since if there are no questions, can we move to the quiz? Yeah, you can start, Bala, you can share the quiz questions.
Yes.
So we may not have much time for waiting for a response unless you all are keeping your fingers ready to type in the chat box.
Mm-hmm.
it full screen? Yeah, perfect.
Moving to this section. Good evening, everyone. 15 to 16 questions are there. First question, 14 years old child with the complaints of abdominal pain and distended abdomen, developed a respiratory distress. Chest X-ray done showed here. Ultrasound screening showed a 400 ml. Immediate management for this child.
You can give the answers.
Malignant pleural effusion was there. Large ICD was inserted.
So what is this image and what precautions are required before this imaging? Any guesses? Okay. Please click on the answer. This is a FDG PET scan, which is showing a huge mass involving whole of the abdomen, pleura, and bone marrow. We need to avoid dextrose containing infusions 6 hours before this imaging.
On moving to second, 5 years old child with the complaints of fever for 1 month, facial puffiness, periorbital edema, breathlessness when lying flat. Had a good urine output. Vitals are normal with CBC showing a WBC count of 74,000. What will be the possible diagnosis and what is the next imaging modality we can do for this child?
I think you can unmute and say answers as well.
No, that may cause problems. Yeah, they can. Bala, give the answer.
With SVC syndrome, we need to do chest X-ray and CD chest.
Okay, the next quiz, please. So we have the 16 years old boy who is newly diagnosed with AML, who is saturating 92% on room air. His WBC count is 4 lakh and the chest X-ray is clear. What is this condition and what procedure was performed? Any guesses? So this child is having, please click on the answer. Yes, Ajita ma'am has posted the answer. So this child is having hyperleukocytosis with pulmonary leukostasis, and the procedure being done is leukapheresis. We can see that the myeloid blasts are floating on the leukapheresis bag. Well, I can do the next quiz.
On moving to next one, which drug was recently approved for RSV prophylaxis?
Narsimha.
Yes,
Good.
sir. This is a long-acting monoclonal antibody. Single IM injection will provide 80% of the immunity.
So these are Pascals working hard to keep out these tiny rascals. Which patients need this? We would have seen it in multiple places. Any guesses? Okay, please click on the answer. Neutropenic patients, yes. Where? Yes, this is a positive pressure room. This is a pressure gauge at the entry. So we use it in the setting of treating bone marrow transplant patients and also in the operation theater to keep the tiny bugs away.
On moving to next one, where you will find this and for which patients? This is a negative pressure room for airborne inflammation, usually done for varicella, measles, and tuberculosis.
Okay, as you can see, this is a 9-year-old boy who is diagnosed with Burkitt's lymphoma. His uric acid and phosphorus was normalized with treatment. He is on rasburicase, hyperhydration, and steroids. His urine output is good. His vitals are stable. You can see that his blood gas is still having high lactates. His SGPT is normal. Can you explain the reason for this high lactate? Any guesses? Yes, a type B lactate, okay. Yes, this is otherwise called as Wartburg effect, where when there is a high tumor burden, the cancer cells have lactate dehydrogenase A enzyme that preferably converts pyruvate to lactate.
And moving to next, 2-year-old child with Fanconi anemia, post hematopoietic stem cell transplant, day plus 60, had a severe hypertension on 5 antihypertensive drugs, proteinuria, HB of 8, platelets of 30,000. What is your diagnosis and a specific drug given for this condition? This is a case of a transplant-associated thrombotic microangiopathy. Drug used is eculizumab, which is blocks the C5 complement protein and preventing the C5a and the C5b9 membrane attacking complex, and inhibits the terminal complement cascade and preserves the proximal complement cascade. Used in TATMA and atypical HS post-transplant patients.
Okay. So this is the next quiz, where this is the 8-year-old child on post-transplant day plus 14. The WBC count jumps from 0 to 200 and then 2000 in 48 hours. The child develops rash, tachycardia, hypotension. So what is this condition and any specific treatment?
Engraftment.
Yes. Aditya ma'am has posted. So this is engraftment syndrome. Okay. This is otherwise also because of cytokine release. So we call it as a cytokine release syndrome. The treatment. So we use tocilizumab, monoclonal antibody to soluble and membrane-bound receptors of IL-6. This can be used in cytokine release syndrome, post-CAR T cell, and post-hematological stem cell transplant.
Next, a 6-year-old child diagnosed with thalassemia underwent Hsct, day plus 60. Child had a profuse greenish loose stones with the skin rashes. What is this condition and most likely, and what is the drug used? GVHD drug used is roloxatinib, which is available as a Jakavi 20 mg. Selective competitive inhibitor of Janus kinase used in GVHD and the primary HMH.
Again, the drug quiz. So this is letermovir. Can you tell the clinical application in hematopoietic stem cell transplant? Yes. Yes, for prophylaxis against CMV.
Next is a 6-year-old child with a Fanconi anemia, day plus 60 of post BMT with the complaints of abdominal pain, diarrhea, abdominal distension was there. X-ray done shows here. What is your diagnosis and management? X-ray showing pneumatosis intestinalis. Management is a conservative management. We kept milk per oral and injection metronidazole was given and used a hyperbaric oxygen therapy.
So this is another scenario where the 11-month-old infant with osteopetrosis on 35th day of hematopoietic stem cell transplant becomes puffy, develops large hepatomegaly, no jaundice, stable vitals with a total count of 3,000, hemoglobin 12, and platelets of 25,000. The infectious markers are negative. What is the most likely diagnosis? Any specific drug? Yes, it is VOD. So the drug will be. Please click on the answer. This is a sinusoidal obstruction syndrome. So defibrotide is the preferred drug. It has pro-fibrinolytic, anti-thrombotic effect, and anti-inflammatory effect. Yes, diuretic as well. This is defibrotide. This is specific. It is used for a 21-day course. I think in chat there is a discussion about the previous drug, letermovir. Just a small short about it. Letermovir acts specifically and it prevents the packaging of the DNA replication. It acts at the terminal polymerase enzyme, which is very specific for the CMV. So there is no cross resistance, and there is lesser development of resistance to this drug, and the toxicity is also less. So the bone marrow toxicity is also less compared to ganciclovir. So letermovir is preferred for CMV. You can proceed with next quiz, Bala.
What is this product? This is basically Indian CAR T therapy targeting CD19 used in refractory or relapsed B cell cancers, leukemia or lymphoma. Developed by IIT Bombay and Tata Memorial, offers a highly affordable alternative to international CAR T therapy. International CAR T therapy cost around 3 to 4 crores. This cost around 13 lakhs, which is 1/10 of the cost.
So please post the picture as well. This is a 2-year-old child. Oh, picture, it has come. Okay. Please go back, Bala. This is a 2-year-old child on AML on chemotherapy with profuse bloody diarrhea and abdominal bloating for past 1 month. The child's stool showed C. diff persistently positive despite oral vancomycin and IV metronidazole therapy. All the antibiotics are stopped. What will be the one last treatment option? Yes, sir. It is going to be fecal microbiota transplant. Please post the picture. So there is transplant from the healthy donor. The stool is prepared and then it is given post pylorus to avoid the destruction by gastric acid.
This is the last question in the quiz. Identify this chamber. This is a biosafety cabinet to prepare chemotherapy, protects the personal and environment. That's it.
Thank you all for participating enthusiastically.
Thank you, quiz masters. You can stop sharing. Yeah. You can stop sharing the slides. Thank you. I think we've come to the end. And thank you all for the patient listening and for all those who are still here. We had at least, I think, some 72 or 73 at one point.
Yes, it was.
Thank you.
Dr.
It was
Saurav?
it was very informative like webinar for me. Thank you. First of all, thank you the youngsters, Sweta, Avinia, Milin, Ria, and Indumati and Bala Vignesh. Thank you, esteemed panelists, Dr. Eber, Dr. Sasiran, and Dr. Ravi. And last but not least, Dr. Indra Jagamar for moderating the session and, in fact, organizing the session. Thank you everyone. We'll
Thank
see
you
you
so much,
another
everyone.
session. Thank you.
Thank
Good
you.
night. Thank you.
Bye. Good night, everyone.
Thank